and the organizing committee by inviting to join the 5th anniversary of the V Symposium. And the topic I'm talking about today is how best to treat a retrograde type A LD dissection or the intramural hematoma. I have nothing for disclosure. So I think in LD dissection, that tear-oriented treatment surgery has been widely recommended, and especially in the retrograde type A LD dissection or intramural hematoma, the arch replacement or the frozen elephant trunk really carries significant morbidity and mortality. And there has been reporting talking about a spontaneous retrograde type A LD dissection has a better favorable prognosis than patients with antegrade LD dissection. So there has been some inherent treatment strategy different for the treatment of acute type A intramural hematoma between the eastern and western based on the better medical treatment mortality in the eastern area than the western area. So we are thinking that the retrograde type A intramural hematoma is really a subgroup of patients who can really benefit from the Tbad repair as we treatment for the type B LD dissection. So things Professor Dag that has been published is the first case treated retrograde type A dissection. There has been several publications afterward, and all this study reporting on the Tbad on the retrograde type A intramural hematoma, it shows that the favorable LD remodeling, both ascending and descending, and very low rates for the retrograde type A LD dissection, and the tear-oriented Tbad procedure shows favorable outcome with almost 100% of technical success. This is another publication talking about the intramural hematoma type A that treated comparing between the Tbad and the medical treatment. The 5-year result has much better in the Tbad for the freedom from adverse LD event and also the survival benefit to the medical therapy. So this is our study comparing the Tbad and the open repair, and no difference in 30 days in the follow-up mortality. And we had the Tbad repair with lower early mobility and the better descending LD remodeling. And this is the study, the report from the IRA for the early outcome of acute retrograde type A dissection with all 3 groups of treatment. And they concluded that retrograde extension to the arch have variable early mortality rate compared to the classic type A dissection. Retrograde type A dissection has a significantly lower early mortality. And they think that the subset of a group, the patient with acute retrograde LD dissection can really benefit only from the medical or endovascular approach rather than the surgical approach. Then this is the Professor Schroed and the study treating on the acute retrograde type A intramural hematoma, also including all 3 different treatment strategy. And they also conclude that in the medical treatment, 85% patient conversion to the Tbad or open repair, and no significant difference from the 30-day and the follow-up mortality between the open and the Tbad repair. And endovascular repair is an option if the maximum diameter of the sending is less than 50 millimeter and the IMH thickness is less than 10 millimeter. So there have been some commentary and also the conclusion from the IRA that management for the retrograde type A intramural hematoma that Tbad represent the option treatment for this patient. So these are the guidelines from the AATS and European Journal of the Cardiothoracic Surgery really has pointed out for the retrograde type A LD dissection that descending Tbad alone can be reasonable in selecting the patient. In the traditional Stanford and the Tbad classification, actually neither classification address the location of the primary entry tear, only the area of the involving of the dissection. So I think that with the newer SVS and STS and the European classification really focus on the location of the entry tear and the extent of the involvement. And we really hope that with this data can really show us a treatment guide for this, with this entry tear location for the different treatment modality. So we think that for the uncomplicated type A LD dissection, medical treatment as a first-line treatment is reasonable, and open repair if become complicated and delayed Tbad if the IMH persists or enlarge, and medical treatment if the IMH regress. And for those with high-risk figure, urgent Tbad is indicated and open repair if become complicated. And if the patient comes with the complicated and open repair may be required. So in conclusion, I think that risk stratification in patients with acute type A intramural hematoma is really suggested. And including all the classification, I think including the primary tier location is also very important. And I think either for the type B or type A OD dissection, the primary tier coverage principle is the goal. And the retrograde type A intramural hematoma in selecting patient, Tbad can offer a potential treatment option. Thank you.